Hello, everyone. My name is Janelle Simmons, and I am Manager of Programs at Sigma Xi, the Scientific Research Honor Society. And welcome to our next installment of our virtual COVID-19 Distinguished Lectureship Series. I would like to thank Mark Imhoff, the chair, and the Committee on Lectureships for coordinating our sessions over the last few months. So today, we're doing something a little bit different. We are taking a trip. So we are taking a trip to France with our speaker today. And to introduce our speaker, we have our moderator, Dr. Kiki Sanford.
So Kiki, thank you so much, Janelle. Yeah, thank you. Thank you, everyone, for joining us today. We are back again for another informative and enjoyable session discussing the science of COVID-19. If you've been looking at COVID-19 numbers around the world and have questions about why the disease doesn't seem to spread the same everywhere, our speaker today will hopefully have some answers for you. Here to talk with us specifically about tracking COVID-19 on the African continent is Dr. Jessie Abbate. Dr. Abbate, and I asked about how to pronounce her name yesterday and just totally went French because I was thinking Montpellier and France. Abbate? Dr. Abbate is an infectious disease ecologist and epidemiologist working with the World Health Organization through the GRAPH network on global public health. Dr. Abbate is also working as a geospatial epidemiologist and data scientist with geodata intelligence company Geomatys, and as an adjunct researcher at Laboratoire TransVIHMI in Montpellier, France. Thank you so much for joining us today. Before we jump into the introduction of the topic, we are going to be accepting questions through the chat today. So if you have questions, please enter them there, and I will relay the questions at the end of Dr. Abbate's research presentation. She will be presenting her work for about 20 minutes, and then we will get to question and answer and conversation. So I look forward to learning along with the rest of you. Dr. Abbate, thank you for joining us.
Thank you very much, Kiki. I'm very excited to be here and very appreciative of the opportunity to talk about this. What I am going to be talking about today is a lot of stuff that's actually not my work. It's really just to show what sort of the issues are and some of the initiatives I'm involved in that we're trying to put forward to help solve some of the problems. So there will be a lot that has been pulled from the web, a lot that has had an enormous amount of people behind it. And I want to acknowledge those people, just kind of blanket to say this is not all my work. So COVID-19 in the African continent. First, I'll say why I'm interested in this, why I got interested in this, if I can figure out. Oh yeah, there we go. So personally, my research has focused on the ecological and evolutionary drivers of disease distribution and how that can influence the prevalence of diseases and also the severity of diseases, and how understanding those mechanisms can help with management decisions and things like predicting and understanding pathogen emergence and reemergence. And so I'm going to tell you a little bit about what's going on in the African continent with COVID-19. And then I'm going to talk about two initiatives, one being a global health spatial data infrastructure that we're putting together, and the Epi-GRAPH Hub, which I'll explain in a little bit. So the big question has been that across throughout this epidemic, it was pretty evident early on, and it remains the case that there just weren't as many COVID cases in Africa as in the rest of the world. And this held true even when we corrected, when you correct for population size. And so this is the per capita coronavirus attack rate, so the cases per 100,000 inhabitants. And it's very clear that can you see my pointer?
Mm-hmm.
So in the African continent, those numbers are much lower than elsewhere. And if you look, I mean, just the striking difference is huge when you look at the numbers. And so the big question has been, why has this happened? And an early study sort of looked at this and said, oh, you know what? I moved that. So some of the hypotheses, one of which has been that Africa maybe is just not as connected globally, that when you have an epidemic, that when it arrives is very important for how fast it propagates. And if you look at, for instance, global imports, there's a little bit less in the African continent than elsewhere. Also, air travel is much, there's a lot less connectivity to the rest of the world, especially to China and Europe and the US. And at the company that I work with, Geomatys, we actually looked at those flight data. And it was pretty evident that if you look at the connectivity to Wuhan, so whether there was a direct flight and the number of flights, so 1 being the most connected and 3 being the least connected, versus their time to first reported COVID-19 cases, that the African continent really ends up being very dominant in the least connected categories. However, it doesn't explain why once it arrived, it didn't propagate as fast. And so another one of the hypotheses is that I am translating in my head the taux d'urbanisation. The rate of urbanization is actually much lower in the African continent as well. So people actually live are much more dispersed in the cities. So when this pathogen arrived, and it arrived into the urban centers, and we've seen that in the data from Africa, that it really arrived into the urban centers, and it stayed in the urban centers for quite a while in most countries before spanning out. And as it spanned out, it really didn't move as fast as it's moved, say, in the United States. So here's where some people looked at this distribution and said, maybe it has to do with malaria, because this is the distribution of Plasmodium falciparum, and it is mostly prominent in the African continent. And I think that it was a pretty controversial study that looked at what we call an ecological study, where you try to look at different factors. And the thing is that there are a lot of other things that correlate with this. And I'm afraid that some of this actually might have fueled the interest in the hydrochloroquine use, which because a lot of people are using hydrochloroquine and in other areas of the world where malaria is dominant. But I'm skeptical of this being a major reason for this. However, it is something that does need to be looked at, and there are a number of other pathogens that have similar distributions in the tropics. So the biggest thing I think that contributes to this is the fact that that cases may not be seen as much in the continent. And that is largely because as we started understanding more about the virus, we started understanding what are the things that cause people to have poor reactions. And that is age and pre-existing conditions. And if we look at, for instance, the age structure of the African continent, there is a lower life expectancy at birth, which correlates with age structure, just that the population is much younger than in other places in the world. but also rates of other underlying conditions that might correlate with obesity. For instance, like diabetes and heart disease. These kinds of things may actually be lower in the African continent, meaning that you have lower death rates. And when there aren't a lot of deaths or severe cases, it can be hard to know who to test and when to test. Because we saw in the rest of the world that a lot of times we didn't see the epidemic until people started dying. And if you look at, for instance, testing capacity, which is another big, another large hypothesis, is that we just don't have the data in the African continent. It's true that access to healthcare is much lower in the continent, and we know this. However, if you look at the test positivity rates, and this is from our world and data, but the data that we've actually been looking at from that's come in through the World Health Organization shows the same thing, that the test positivity rates often don't go far higher than 15%. And there are a lot of other places in the world that have either that rate, that same rate, that positivity rate, or higher. And so it can't just be that they're not testing enough, because if they were testing all of the severe cases, then you would expect very high test positivity rates. And that's just not the case. Interestingly, what could be happening is that if you don't test because you don't see the cases, there could still be cases that are propagating. And what we've seen from seroprevalence studies is that whereas in the US, for instance, or in Switzerland, we see about 1 in every 12 cases. So 1 in every 12 cases, or 1 in every 10 to 100 cases, are actually, we actually can detect them by testing. However, in a few studies, and I think there are actually more now, so in Niger and in Kenya, that rate is at least 1 order of magnitude greater. So we're only detecting 1 in every 5,000 cases, or 1 in every 1,200 cases. And so that suggests that it is spreading, and we're just not seeing it in the continent because we're not testing for it. And if you look at just the number of tests that are given, that's not really a great indicator, because you're going to test when you have cases that you suspect. And so that number is going to go lower if you don't suspect cases. So let me get this back here. So the other really big thing that I think is very appreciated is that the African continent, most countries went into very strict lockdowns very early on, even before cases were detected in the country. And so this is not data, it's just points, because we haven't quite, I haven't seen, I'd be interested if someone has a reference for someone who's actually mapped out these the response to the COVID. But this is the OECD's COVID policy tracker, and you can go into each country and look at what they've done and what they're currently doing. And I think if we look at that we'll see that those lockdowns that happened really early on, and in those urban centers, and a lot of times across the entire country, really prevented the spread of the disease. So some of these biases I'll just summarize. So the connectivity of the continent to other continents, and also within the continent. Mortality rates that may differ, and determine how much testing is done, and just surveillance, the ability to test, access to healthcare facilities. So in addition to these biases, we've also had met several challenges. So the first is, well, all of this relates to data infrastructure. How do we get data out, and how do we use data to understand how the disease is spread, and how we expect the disease to spread globally. And so, looking at the data collection for an emerging epidemic and interoperability, which I'll talk about, on a geographic scale, is very important. It's important to have these types of correlates. Last week, we were talking a lot about correlates and having these data available, and how it's very difficult to get all of the data. And so one of the things that we're doing at Geomatys is working to build a global health spatial data infrastructure. So what is a spatial data infrastructure? So each of those maps, I showed you a bunch of maps, and those came from a bunch of different websites. And they oftentimes, the data are shared to a central database, or a researcher has gone along and collected it from individual countries. And each of those maps may be created differently, both technically and sort of the way that the data are collected underneath, and making those data and those maps interoperable or fit together, so that you have in the same position or in the same geographic location all of the data that you want to compare, and in a comparable way, is actually technically very difficult to do. And so a spatial data infrastructure actually helps to pull together these data, georeferenced data, put them together, and allow the user to manipulate them in some way. And so we work with the Open Geospatial Consortium, which is a worldwide collaboration to develop and implement standards for different geospatial needs. And it was really one of the ways that I like to explain this is that it works a lot with satellite data, because these satellites are being launched and they're producing so much data every day, or many data, sorry, it's plural, so many data every day. And those data cannot be housed in multiple locations. You can't just download all of those data and then manipulate them to get the information you need. You have to actually go to the data. And this is a big problem for a lot of big data infrastructures now, is that you have to go to the data, and that is a technical challenge. And so this is so the OGC makes standards so that when you go to get these data and pull them in and work with them together, that these standards allow you to understand how the data are structured and to use them, and so that everyone can use them in the same way. And so this is the sort of the body that helps to pull those things together. And they've started an initiative to put together a global health SDI. And I'm going to show you what an SDI looks like. And it's basically a way to pull in all these data from all different types of websites that pull these data that actually produce the data, and then allow it to be manipulated. So here's an example of a spatial data infrastructure that the company I work for, that's what they specialize in. So they pull together so this is an interface where you can actually select what data layers you want from a library. So you don't have to go looking for the data. We want to pull all the data that could be potentially useful for health risk assessment, and put that into a single location. And then you can manipulate the data. You can stylize it. You can compare. So by manipulate the data, I mean you can actually, run analyses within the environment. And that helps people so that if they don't have the ability, for instance, or the infrastructure to pull that data into their local machines, then they can actually do it on the cloud. And that's really important, especially for decision makers, I think. So I'm trying to advance. So how can these data, so some of the really neat ways that, that actually Earth observation data or these satellite data are being pulled in for epidemic response is that there was a study out of Harvard looking at the number of cars in hospital parking lots and actually counting that in real time and looking over time as to how whether or not there was a spike in people seeking care. And so that's something that could be really used in order to look back in time to see, for instance, they were looking in Wuhan to see how far back in time they saw spikes, and it's also something that can be, or at least the idea can be launched in places that are hard to get data from. So we can all, this is what, so it's not just these static maps that you can build into a spatial data infrastructure. It's these analyses through time. So here's the before and the after shot of I think a tsunami that came through. And so the idea is that you have these spatial temporal data that can be analyzed all in the same place. And so it's not just static. And that's a real technical challenge that the epidemiology field has not really fully utilized. We can also add, and this is something that's cool, these moving features. So these are actually boats, but we can actually do this with animals. We can track animals and people. And I mean, I don't think we do. we don't track people, but this kind of thing can be done. And you can actually look at trajectories, not just where someone left and where someone arrived on an airplane, but you can actually look at how they traveled, what routes they traveled. And you can do that using geolocalization. I'm sure you've heard of the Facebook data and the Google data. And so that kind of stuff can be integrated into a spatial data infrastructure and used. So I think it's really powerful and interesting, and something that I'd never thought of before I came to work with these guys. And so so this is actually work that we're doing in collaboration with HSR Health, which is a company in the United States that has used this type of technology to actually show us where we need to find to allocate ventilators, respirators, because there are higher mortality risks in certain areas. So they've been working with FEMA to distribute those kinds of things. And they're actually working with the GRAPH network now to build those mortality and transmission risk indices for the African continent. And so the last thing I'll say is I'll mention the Epi-GRAPH Hub and the epic challenge of data sharing and analysis in the African continent. This, for instance, is a map of countries that have specific data sharing policies, and you'll see that there's a huge absence from the African continent. Thankfully, we work with the World Health Organization, can see a lot more than is shared with the rest of the world. And so this was a project that was developed by Benito and Puma, who works with the Health Emergency Information and Risk Assessment for the Regional Office for Africa. And he and Olivia Kieser in Geneva built this network of people from all over the world, researchers from all over the world, and analysts and reporters from all over the world. Including the African continent, people we call the in-country people. So these are the people on the ground who have connections to the ministries of health and the local World Health Organization offices. And what we do is we were hired to help and build reports and analyze the data that were coming out of their 47 member states. And so how this works is that actually an Excel sheet, a template is sent out to the countries. It's filled out, oftentimes duplicated and changed, and sent back to the World Health Organization's regional office. And this is quite time-consuming and costly in terms of human resources, and prone to errors, and it's been a real challenge, but this is how they do it, and we've been able to pull the data quite well. I can't show any of it to you because again the sharing is very there's a lot of issues with data sharing, but a lot of the countries are very interested in collaborating with us to put together reports that will be shared, and that has really come from us talking with the in-country people and the people in the Ministry of Health to show them what we can do when we have clean and usable data. And how that can actually help them to inform their decision making and to encourage this type of data sharing. And we've just had such positive responses from the countries. We've had so many great collaborators in country that have wanted to learn learn the statistics, learn about making web applications, and it's just something that has been really positive, and we think can really be a platform for even future epidemics. And so what we're actually doing is creating a web application so that all of these indicators that analyses that we've done to furnish, sorry, that is a franglais there, to give to the decision makers. We want them to be able to click on their country and look using the data that they've furnished in a completely secure way, but be able to pick out the indicators that they want to see and quickly get the information that they need. Not to take, a month or two. A lot of times the delay is a month or 2 months delay in actually getting analyses back because of the human capacity. And the capacity exists, it's just not organized as well as it is in some other places. Although last week we heard that it's not well organized even in the US. So this is not an Africa problem. This is a pandemic problem. This is something that we have had a problem with and has been known about this for decades, and it really hasn't been built. And so we're hoping to try to at least build it from the African continent, and hopefully to build it out from there. And what you can see is that actually a lot of the digital health applications that have been on the rise and are actually used in a lot of the tropics are going to be immensely helpful. And what we're hoping to do is actually collaborate with them, such as the DHIS2 and REDCap, in order to feed data that has been structured by the countries in a way that is useful for them and for epidemic response, in a way that will be automatically able to produce reports and visualizations that can help decision makers. So hopefully that challenge will be less the next time around, but we'll see. So thank you very much. And I just want to shout out to all of the people that have gone into this, and you should check out the GRAPH Network and Geomatys. And thank you.
Thank you so much. It's so fascinating to be able to see the way that technology is influencing our ability to not just predict, but also manage. And the slide of yours that really stuck out the most to me was the one of the data sharing between different countries and different areas. The United States wasn't even up near the top. It's somewhere in the middle, which we've obviously seen some issues in our data sharing over the course of the pandemic. But we know that different regions do respond differently, and different regions have different needs during the pandemic. But the EU and European countries seem to be sharing data a lot. Is there anything that's visible as to the differences in data sharing that we see and how well different areas are responding in real time to the pandemic?
That's a great question. I know that, so I'll speak to one issue that I've seen in the US, for instance. What we've been very, very interested in is how, at least at the beginning of the pandemic, we were very interested in how the virus was spreading, how far the virus was spreading. And in order to get that kind of information, you need much finer scale information. So you need not just country information, you need county information, which most of the US was sharing, but what would also be nice would be the zip code. And most counties were not sharing their zip code, or states were not sharing their zip code data because and I was told that this was largely because of those pre-existing conditions and racial disparities in the United States, at least, that were very evident if you looked at the zip code level data, that there were disparities that would stand out and be politically difficult to deal with. And I think that this is something that has been the problem sort of in Africa, but and maybe less of a problem in the EU, is that in the EU, it's again the European Union. These political boundaries are a little more fluid. And so there are standards. If one country shares their data, another country is likely to share their data. I don't know whether the EU has sort of policies that go across all countries, but I doubt that that's the case, that there are standards. But it just seems like it's much more open. And in the African continent, we've seen is just not necessarily an unwillingness to share the data, but sort of a lack of the sort of systems that would allow them to easily share the data without compromising privacy. So in the EU, for instance, in France, everyone has a nice little card, our carte de santé, and we all have a number, and our entire record is on that number. And so it's very easy for the country to track each individual, and also to have a centralized database where they can disaggregate the data. So I'm sorry, aggregate the data.
Aggregate, yeah.
Where they can aggregate the data and then share that. And in a lot of the countries that we've been working with in the African continent, we've seen that they actually don't have. Some of them don't have a great system for differentiating between individuals. And so when you have that, you have to oftentimes use names. And so we have to, anonymize the data in order to work with it. And it can be difficult because it's hard to know whether there are duplicates, or, when someone's record gets updated, if they, if that's someone who'd already been seen, or if it was a new person, who got entered and just were missing some data. So that I think is more the underlying problem. Is just that the systems are less developed in the African continent. And so.
Yeah. Do you also have issues on the African continent specifically between just cultural differences between the different countries and how they want to talk to each other or are willing to talk to each other?
I mean, I am sure that is an issue. I don't deal with the diplomacy
Right. Yeah.
that goes into I mean, so I'm sort of in charge of the analysis,
Yeah.
And coordinating the analysis teams. But our main coordinator, they've been really, speaking with countries on, and I've been in a few of those meetings on a weekly basis, trying to just seeing the benefits of sharing the data, and a few of them are very receptive, but I think in a lot of ways it's just not high on their priority list. These kinds of things, the kind of thing that we're trying to build right now out of necessity, is really what needs to be built in quiet times.
Yeah.
It can't really be done in the middle. If you try to push something in the middle of a crisis, especially when it's linked to an economic and social crisis, because I mean, these countries, they did the same thing that we've all done, and they're shutting down large sectors of their economy, and so they're suffering. Even if they're not suffering, dying from COVID, they're suffering in the same ways that, I mean, just the global shutdown, the global economy is going to really affect them, and a lot of these countries. I mean, you can't, that's another thing, you can't really, a lot of people actually, and studies, I mean, just the way that we speak about the African continent is in a very homogeneous way. And it's a very heterogeneous continent. I mean, yes, there are a lot of things that are very similar between many of the countries, but there are some countries that really stand out, that have been really handling things much better or worse, and for many reasons. And so it's important to remember that as well.
You mentioned malaria in the presentation, but Africa, the Western Africa specifically, has also been dealing with Ebola and the epidemics of outbreak there. And that's some smaller regional epidemics have been an issue in Western Africa for some time. Have there been any data collection processes and data sharing processes that have been useful during the pandemic as you're putting together all this data for the entire continent?
Yeah, so yes. So for instance, I mentioned the DHIS2. And so that is an application that was developed, or it's really an entire system of data collection and sort of what we're doing, the immediate summary statistics of the data that are collected. That was developed by a Swiss group, I believe, and it's been accepted in most of the African continent, and it's used for things such as malaria, and it was used for the Ebola outbreak, and it's actually been used, for instance, in DRC for COVID data collection, also in Senegal, I believe, if I'm remembering correctly. I work in a lot of different places, and I can't remember the specifics all the time. But I believe it's Senegal that has really been using the DHIS2 in a very effective way. But there have been other countries that tried to use the DHIS2 for COVID-19 and found that it was not helpful. And they abandoned it pretty early on. And so that is something that is what we're interested in. We want to work with the people in the country to say, okay, what system do you have? What system do you use? And what can we help with? What can we either train someone on your team to specifically help make the application work for your purposes, or do you need outside help? that's something we're really trying to recruit as many people into the network, because it's really about capacity building. And so what we really want to do is work with the organizations that have developed these applications, to make sure that they are ready for a pandemic situation where it's not, that it's flexible enough to meet the needs of an emerging situation. And that's what's really important. So there have been a few countries that have been able to use it, and a lot of countries that haven't. But they do use it for other reasons. So it might not be the Ministry of Health, it might be research groups that use it for a very specific infection or purpose. And so it's really a matter of showing how it can be super helpful in an emerging situation, and then just helping to put the people and technology in place to make it operational.
From the questions that the audience are asking, Statistics Columbia University would like to know what statistical techniques you're using to clean the data that you get from Africa.
Ooh, statistical techniques to clean the data? Yeah. Well, it has been, thankfully, there have not been so many cases that in many places we've had to do a lot of it manually. So what we've currently done, so we take the data and we generate some just generate some tables and look at how the distribution is, look at just very simple cleaning. I mean, this is not rocket science. This is just, are there typos? Are there, making everything uppercase so that, because in R, for instance, case matters. And this is a problem throughout. I mean, it's really a very simple problem. Is just, I mean, these are people in hospitals that are filling in these lines, and they're going quickly, and they're in a situation where if a typo, it doesn't matter to them, because they can't see down the line like how it's going to really impact it, and they don't understand like how much work it is to figure out whether or not someone's switched the day and the month. Because in many African countries, they follow like we do in France, that it's the day, then the month, then the year. And oftentimes, even within a country, in one column, they may switch the day, there may be day and month switched very often. And so in some countries, it's been actually impossible, because when you have March 4th and the 3rd of April, you don't know which is which. So, when it's past,
and that makes 12, a big difference.
Yeah. So, and this is a problem for all data sets. And I mean, a lot of people are used to this. We've used some machine learning to try to clean really messy typo kind of problems, and data that are, for instance, free form, so occupation and some of those kinds of things. So we've tried to employ some higher tools to do that with, but it's really been just going through and saying, okay, what has this country done that needs to get fixed? And then we've actually given them back reports. So this is where, I mean, it's not just that our group is creating an application, it's that, or just making reports for them. We're actually working with the country to say, okay, this is what you guys need to make sure you're filling in correctly, because we can't fix it because we don't know, 3-4 or 4-3. And here are some things that would really improve the outputs that we can give you. And that's been really positive to have sort of, this feedback. And they explain, what their limitations are. And so that's all information that can help in the future. And so, yeah, so it's the answer is it's been it's taken a lot of time.
You're talking about a lot of working locally and kind of on a regional basis and on a country by country basis. Is there, can the African CDC, or is there an African Union that is involved and can be involved in helping to, or is involved in organizing this sharing of data?
That is a very interesting question. One that I have realized I should know the answer to. I mean, I will say that so the region itself, other than the WHO Africa office and the individual ministries of health, those are the only people that we have been working with. There may be people within the union that are in those places, but there's no centralized, at least for working with the WHO, there's no other centralized group that I know of. It may very well be, but I have no information on that.
Yeah, so then that just seems like it just adds an additional challenge, because from a logistical standpoint.
Yeah. And I don't know why that's not the case, because it should be the case. I know that with you mentioned the Ebola outbreaks in West Africa. And I know that was sort of a wake-up call for those communities, that they needed to make sure that they had, the proper, that everyone knew the proper sort of chain of command of how to report cases within a country and then between countries. Like, who is responsible for sending that information to make sure that multiple people don't send it, or that or that it's not tragedy of the commons and no one sends it. And so building those systems was really important after the Ebola, the 2014 Ebola outbreak. And so I think that's one reason why some of West African countries have been very successful at controlling their epidemic and getting data out. So I think there's been a lot of movement in recent years. And certainly the digital health movement has been, I know one of my colleagues in Guinea has been very big in pushing for this. And so, and I know in DRC that my colleagues there are very interested in making sure that it works for COVID. And so it's just a matter of putting the links in place on really removing the blocks to the flow of data, because the data are being collected in most places. It's just that, it's either on paper and or it's just in some format that is just not shared in a consistent way. And or if it is shared in a consistent way, it's not shared, with the WHO, for instance. And so there's a lot of work, and I know a lot of people in the US have criticized the WHO and especially about China, but they don't understand that, in order to have access to a country's data, you have to build trust. And you have to also allow them to share data with you without sharing it with other people, because they are trying to help the country contain a crisis, and they can't do that. They can't do that if they say, okay, well, you can if you share it, if you don't share it with everyone, then we won't help you. And so I think there's a lot of understanding that needs to happen on the world stage. And I mean, I don't speak for the WHO. I do not speak for the WHO. I'm a contractor, basically.
Right.
But I am a big supporter of the WHO, and I think the work that they are doing is, I mean, no one else is doing it.
Yeah.
And for instance, the US says, oh, we're going to go out and do it ourselves. They are not going, the world community does not trust the United States. And rightfully so. They've done a lot of things to, stealing data or taking control of data and not letting the countries, and there's a lot of, talked a lot about parachute science and colonialism. I mean, this is a big problem, and you have to, even us, we are not trying to impose a new, these digital health applications or a web portal. We are asking, what do you need, and how can we train your people to build it for you? And how can we support you to do whatever makes this, useful for the future for you? And who amongst you wants to do it? And so this is, I think, just really important, the idea that, the WHO, it's unifying, and it's facilitating these types of collaborations. And I think that's important.
Yeah, having a facilitator is always important. And yeah, your point about trust is so well taken. Katie Burke would like to know if you can...
She's an old UVA buddy.
Oh, yay. If you can reflect a little bit more about why many African countries do have a low per capita SARS-CoV-2 attack rate, and what data are really needed to answer the question fully, and when might we have a more concrete answer?
Well, certainly the seroprevalence studies would be very helpful in more places. It's interesting because in a lot of ways, I mean, we've seen it peak and then go away in many African countries, and so it's not going to do that if we've all of a sudden stopped. If it hasn't really stopped spreading. So I think that there's a mix of non-detection, of a lack of detection, but again, it's because these lower mortality risks, and that may change. We never know. It's still an evolving situation. We don't know what the long-term consequences are. We don't know if getting it twice is more dangerous than the first go around. We don't know these things, and so I think that is it's still an open question. And I think that we will know more, obviously, but I think that the seroprevalence studies will help, because it's clear that it has spread. But I think that a lot of these countries need to be recognized for having really well handled their epidemics and gotten rid of the disease from their populations.
Yeah, you talked a bit about the urban centers being very similar to urban centers elsewhere, being where the disease has concentrated. Can you talk a little bit about
Sorry,
excuse me, Mike.
Crying.
You have a child. I have a cat attacking my backdrop. Can you talk a little bit about the differences? I mean, the built environment is very important for epidemiology and infectious disease spread. Is there any data on the buildings and ventilation in the urban centers versus rural areas, and whether that is possibly a part of the difference? Pat Hallquist is wondering about pathogens and ventilation.
That is a really good question, because again, a lot of the populations are rural, and even within the urban centers, a lot of the population is not living in enclosed quarters. Or if they are living in enclosed quarters, they're not spending most of that time in enclosed quarters. However, in a lot of African countries, people do spend time in air conditioning inside, especially when it's very hot. And so, I mean, but I think that that's much. I think there is a huge. That's a great question. What I mean, it would be awesome to have those data. I'm sure that geospatially we can actually have those data and look at how building structures compare with the population density in an area, to understand sort of, you know, how many people actually can fit into the structures that exist. And so it may be that, you know, especially in you know, we all saw how, at least everywhere except for the US, we almost, you know, we saw a real diminishing of the epidemic during summer months. And that is in large part because of human behavior. When it's warm outside, you're outside. You're not in enclosed areas. And we know that this virus spreads mostly from person-to-person contact and indoors where it's concentrated. And so I think that is a huge, a great question. And I hope someone answers it. I mean, I'd love to explore it. That's probably what I'll do next week.
Oh, that's fantastic, because that is something that you can look at using the map data and start to put that kind of thing together. So that's fascinating. That's great.
But we also have to remember that not all of the African continent is always in a tropical. There are many places, especially in higher elevations, even in the tropics, where it's cold. So It'd be interesting to see within the continent how that might affect the transmission. But again, like a lot of times when we have the data and at what's been shared in large part has been very much aggregated across the country. We do have a lot of data on that is geolocalized. So it's something that we could look at. But whether we can share it is up to the countries. So, but it's something that I will propose looking at with the data that we have access to.
That's wonderful. Do you have a final comment for everyone on the take-home message that people should understand about how the pandemic is affecting the African continent, and kind of the bottom line of what you've discovered so far?
Yeah, sure. So I think that the real take-home message is that that the African continent is being affected in similar ways to the rest of the world. It's very unlikely that there is some magical component to their populations that is that allowed them to to escape this. But the thing is that they managed to control the spread in most places, and should be commended for that. And I think it's going to be very interesting to find out what the factors are that kept them protected, because that might help us all. We might understand that maybe we shouldn't be putting all the old people together in old folks' homes. So, you know, there's a lot of structure to the societies there that it differs in the rest of from the rest of the world. And so I think it's going to be very interesting. And I don't think that people give enough credit to their ability to respond. I think that they've done very well with the resources that they have. And that should be taken into account when trying to understand.
Yeah, they've done an amazing job, and there's a lot that the rest of the world can learn from what they've done. Yeah. Thank you so much for your time today. It's just been wonderful to hear about the work that you're doing and to become a little bit more informed about what is happening in the world and the issues, the challenges that we are up against globally with data sharing. Everyone, thank you for joining us for another of the Sigma Xi Distinguished Speakers series on COVID-19. Dr. Jessie Abbate is, you can find her online. She's also on Twitter and tweets regularly, so you can follow her on Twitter and follow her research efforts there. And I hope that you will join us again. Our next lectureship is scheduled for November 20th, Peter Hotez, and we hope to see you then. Thank you for once again joining us, and thank you, Sigma Xi, for organizing this speaker series.
Thank you all so much.
Thank you.